Well, again, I think you heard three very interesting presentations. The last one actually, again, bringing more data into a enormous body of research showing that some of the functions that Lori was talking about around care coordination do indeed result in improved quality and lower costs. So we have real-world data and we have randomized control data. And I think our challenge now here is to figure out how do we take some of those functionalities and build them into other programs like fee-for-service Medicare that doesn't have it. I'm just struck by looking at the types of services that are available to certain populations of Medicare, and then in fee-for-service Medicare, nothing. We do a care plan, send them home, and good luck. So I think there's an enormous opportunity to build some of these evidence-based functions into fee-for-service Medicare. And again, you can see the data in terms of multiple physicians, multiple medications, cutting across different providers. We can't really do this effectively unless we have the types of technology available that you've seen from Allscripts and from Marshfield Clinic and Exhale Health as well. So that's really the infrastructure that really facilitates these programs being effective. So I think we have time for a couple of questions. So if you do, would you please identify yourself and whom the question is directed toward?
My name is Andrew Womack. I'm in Senator Kerry's office. I have a question for the first panelist. So you showed I can't remember the specific statistic you have, but it was like 7% of people actually hit the diabetes 3 indications. So what do you think? So ostensibly, there's two things that contribute to that. There's a technological efficacy on one side, and then actually dissemination on the other side. So and HIT would actually help with the dissemination of getting people medications that work. What do you think is the upper end? How close can we get to 100% with existing medications and therapies if they were actually disseminated properly or efficiently?
Well, so it's the question, if you didn't hear it, was it was less than 4%. If you look nationally, less than 4% are at goal for all three of the D3 diabetes goals. And so the question is, realistically, how high can we get? That's sort of a theoretical question. I mean, theoretically, you could get 100%. Practically, that's not the case. If you look at some groups who are really, really focused on this, who are building quality processes into their workflows, they're getting 45, close to 50%, which is huge. And even those who aren't at goal are getting closer to goal. And so even that movement is very, very significant. So we can make dramatic improvements. Will we ever get to 100%? No, but we can do much better than we are currently.
Good. Thanks. Other questions?
Hi, I'm John Miller from Senator Conrad's office. We saw 3 different proprietary tools today, and I was just wondering if you could talk a little bit about interoperability or standards or what we can do from a policy perspective to foster that, because it seems to me, well, these are 3 great tools. If you're moving between care providers, there could be a real problem there. So if someone could speak to that.
Well, I can take the first shot since we do a lot of work in this area. So our applications are typically deployed in communities that have multiple platforms. And so one of the big challenges is how do you move data from one system to another, from one platform to another? And it's not a trivial problem. So it starts with terminology. So there have not been standards for terminology in healthcare. So it's a little bit like, so if I move from an Allscripts system to another system, it's a little bit like moving from Chinese to English. Okay, there's a translation that has to occur. And just like you can't do an exact match always from a Chinese character to an English phrase, it's the same thing with healthcare. But in healthcare, that imprecision can be deathly. And so it really starts with standardized terminologies. And ONC is actually, as part of Meaningful Use Stage 2, is going to require health IT companies to report using standard terminologies. So that means that we're all going to at least have to be able to translate whatever terminology we're using into reference standards. Okay, so that's sort of phase 1. Second phase is then, you have to have standards for how you transmit that data from one system to another. And again, there's a lot of work going on in the industry, much of it led by ONC. There's the NHIN Direct that's trying to simplify those transport protocols. So in terms of what you all can do, it's really continuing, it's to understand the importance, to me, it's to understand the importance of those standards and to continue to push ONC and health IT legislation that really promotes those standards. Because without it, we'll just never get there.
I agree wholeheartedly. The real challenge that we have is the reality of the situation is the vast majority of our country do not live in areas where there's large multi-specialty group practices. They're scattered over large geographic areas. There's multiple different healthcare organizations with multiple different medical records or paper records. And it's very difficult. Communication is not timely. It promotes it's a patient safety issue, and it promotes overuse. And we have patients all the time who have health care at the VA system, get a panel of labs drawn and present to their primary care provider's office and have the same labs drawn again. Why? Because the records from the VA haven't gotten to the primary care provider's office, or if they have, they can't find them in the medical record. So there are some real challenges. Health information exchanges are a nice concept. I think from a patient perspective, they're absolutely the right thing to have. The challenge, like Doug had remarked, is we all have to be speaking the same language, and there's going to be a tremendous lift behind the scenes to make that happen. But I think that that's very worthwhile, and in the end, I think positively impacts the value equation in each of the metrics.
Yeah, I was going to add that I think that this is one area where health plans, such as a special needs plan, can really contribute. Because really, when we're dealing with a member, and this member is accessing healthcare providers across the continuum, so specialists, primary care, the lab, because we've got all this data in one central place, it makes us kind of a natural partner in disseminating this data and information to various providers. So a system like XL Care, and that's exactly what we do with it. Because we have it all at the health plan level, we can disseminate it out to the different providers.
I'll just add that the other important component here is the patient. So as many of you know, ONC and Secretary Sebelius pushed through a bill to, or legislation to allow patients to get lab data directly from labs recently. So the patient can actually be a collector of their own data and make that available to the different providers that they see. So, I think that's an important piece of this that we shouldn't lose sight of. And another area where by sort of liberalizing laws like that and allowing patients to get that data directly, we can help facilitate that.
Okay, thanks. Two good questions. We have another one. We're on a roll. Now we've freaked everybody out since we had two good questions. Others? Well, yes, ma'am.
My name is Anika Chowdhury. I'm with the Alzheimer's Association. And I was wondering how these systems work for conditions that don't necessarily have numbers that you can track over time. So like dementia or depression or...
Well, so a lot of those conditions actually do have numbers that you can track over time. They're different numbers. They're not lab numbers. Okay, they may be, for depression, it may be a patient screening number, like the PQ, what is it, the PQ9?
PQ9.
Yeah. So, a lot of our providers are using things like that to track and monitor a patient's level of depression. You can do the same thing with dementia. So, even the sort of diseases that don't necessarily have lab results that you can measure, there are measures that you can track over time.
Yeah, I would add that that's really true, because one of the things that we do with our house calls program is every member gets a cognitive screen, PHQ 2 and 9 for depression, a pain screen, functional status assessment, and those things do have numbers associated with them that we can track. Again, that information comes back into the health care technology, into our XL Care system, and we can follow those scores over time, and they're available to any clinician that's working with a member.
I think one of the challenges is often, historically, that's been viewed as the softer side of medicine and the art of medicine. And I think my personal belief is providers over time have hidden behind that screen a little bit of, you can't measure this, you can't tell me what to do, this is the art of what it means to be a healthcare provider. And in reality, we can measure a lot of things. I mean, there's a lot of great literature out there to support the fact that we can't say we can't improve the quality because we can't measure it. We have to figure out a way to accurately measure it and portray the story so we can paint a picture and then understand where the needs of the patients are. And some disease states lend themselves to that very nicely. Others are a little bit more of a challenge, but I'm optimistic that as we work our way through this and we gain experience with the ones that are relatively easy, we'll be able to take on the other disease conditions a little bit easier.
We have a final question? Well, if not, I heard Senator Whitehouse twice. If make sure you bring whatever you're sitting with, bring it with you. I just want to thank you all for coming on behalf of the Partnership to Fight Chronic Disease. I think that we've had 3 really wonderful presentations. We were very fortunate to have Senator Whitehouse, truly a real leader in the Congress, join us today on information technology issues. There's a lot of great possibilities out there. I think this is just an issue of finding ways to accelerate some of these best practice approaches, both for preventing, coordinating care, as well as building an information technology infrastructure that would really facilitate this. So I hope to see you all again soon at our next briefing. And if you would, please join me in thanking our wonderful panel.